Hi, this is Dr. Mahadevan, and we're at part 4 of Advanced Airway Management. And as I mentioned, there are the 6 P's of endotracheal intubation. Thus far, we have discussed preparation, pre-oxygenation, positioning the patient, and then placing the endotracheal tube. In this lecture, we're going to focus on proof and post-intubation management. And when I say proof, I'm talking about proof of endotracheal intubation. So again, when we're performing this procedure, in some cases, 6 to 16% of cases of emergent endotracheal intubation, we can inadvertently place the endotracheal tube in the esophagus instead of the trachea. And so when we talk about proof, what we want to prove is that the endotracheal tube is in the right spot. And when I say the right spot, I mean within the trachea. Endotracheal means within the trachea. So you want this tube to be within the trachea. And remember that if we fail to recognize that it's not in the trachea, or if we fail to recognize that it's in the esophagus, which is not good, this can be a fatal error for the patient. So unrecognized esophageal intubation can lead to a number of untoward side effects, and those include a drop in your arterial oxygen saturation, bradycardia, which can eventually lead to cardiac arrest. You can inflate the stomach with air and the esophagus with air, and eventually the contents of the esophagus can passively regurgitate up into the pharynx and then be aspirated by the patient. All of these things are bad. All of these things are complications of esophageal intubation. And as I mentioned before, it is going to happen. It's unavoidable. It occurs in anywhere from 6 to 16% of emergent endotracheal intubations. And you can see from this video how difficult it might be to differentiate between the trachea and the esophagus. So let's take a look. And what I'm showing you here in this video is this is the esophagus below, and then as we lift, we can see the trachea and the vocal cords. And you can see, to an untrained observer or someone who's early in their training, they might mistake the esophagus, which compresses, for the glottis, the opening to the trachea, and inadvertently think that they're inserting the endotracheal tube into the right place, but they're actually inserting it into the esophagus. So we want to prove that the endotracheal tube is in the trachea. And there's 3 ways that we do this: clinical assessment, pulse oximetry, and something called end-tidal carbon dioxide detection. So let's go over these 3 different things. The most common way of determining that the endotracheal tube is in the right place is looking for specific clinical signs. And the most important of those clinical signs, one you'll hear all the time, is, did you see the endotracheal tube pass through the cords? Because that's the most reliable way of knowing that you're in the right spot. So if you saw the cord pass through, or the endotracheal tube pass through the vocal cords, that's going to be the most reliable clinical sign of endotracheal intubation. Other signs include hearing clear and equal breath sounds over both lung fields. And so as soon as you've intubated the patient, oftentimes someone will listen to both the lungs, and they'll also listen over the stomach, because you don't want to hear breath sounds over the stomach. That would suggest esophageal intubation. You want to see symmetrical chest drive with each ventilation. And finally, if you see fogging within the endotracheal tube, that suggests that you're in the right spot. Now keep in mind, although we always check for these 5 clinical signs of endotracheal intubation, each one of them is subject to failure, including seeing the endotracheal tube pass through the cords. You might have thought you saw it, or you might have seen it pass through the cords, and yet sometimes it can end up in the esophagus. So it's important to also look for clinical signs of esophageal intubation, not just clinical signs of endotracheal intubation. So if you note that the patient doesn't have breath sounds when you listen, that they have a gurgling noise when you listen over the stomach, that you see gastric contents in the endotracheal tube, or that you're having a very difficult time ventilating, something that we call poor lung compliance, any of these signs are suggestive of esophageal intubation, and you want to be absolutely sure that that isn't the case, because if it is, you want to remove the tube and reintubate the patient. Another way of determining whether the patient has the tube in the right spot or whether they have endotracheal intubation is to check for pulse oximetry, and you want to measure this on every patient that's intubated. One sign that the patient has an esophageal intubation is a drop in the patient's oxygen saturation. But keep in mind, if you do a good job pre-oxygenating the patient, it may take a while for this drop in oxygen saturation to occur. So don't rely on this alone as a measure of or an indicator of esophageal intubation. Sometimes it can be very difficult to get a pulse oximetry reading, especially in patients that are hypotensive or hypoperfusing. So we don't want to rely on pulse oximetry alone as a way of detecting whether we have intubated the patient correctly or not. That's why it's recommended that in every patient we perform end-tidal carbon dioxide detection. This is a colorimetric end-tidal carbon dioxide detector. And so we attach it between the endotracheal tube and the bag mask device and assess for color change. You'll see color change here in a second between purple and yellow for 6 manual ventilations. If you see this color change for 6 manual ventilations, it's very reliable for confirming proper endotracheal tube placement. So let's take a look. You see the color changing from purple to yellow with each bagging of the patient. That highly suggests that the tube is in the right location. Sometimes you can have false positives with end-tidal carbon dioxide. If the tube is just in front of the glottis, so it's not in the trachea, but it's right in front of the glottis, you might get a false positive detection of end-tidal CO2. And you can get false negative end-tidal CO2. That means you don't detect end-tidal CO2 even though your tube is in the trachea, and this can occur in patients with cardiopulmonary arrest and profound circulatory collapse. So keep in mind again, even end-tidal CO2 detection can have false positives and false negatives. So the reality is you want to use all 3 approaches. Clinical signs, you want to use pulse oximetry, and finally, end-tidal CO2 detection. All 3 of these methods in each and every patient. Once you have proved that the endotracheal tube is in the right spot, you want to secure the endotracheal tube with tape or a commercial device. Repeat the vital signs. This is very, very important. If you detect bradycardia after endotracheal intubation, you should be concerned for what? You should be concerned for an esophageal intubation. If you detect hypertension after intubation, what you should be concerned for? You should be concerned for inadequate sedation. If you detect hypotension after endotracheal intubation, what should you be concerned about? You should be concerned about tension pneumothorax. So important to repeat the vital signs because they may be clues to 3 of these important clinical entities. Always obtain a chest x-ray. Consider sedation and analgesia for the patient depending on their clinical condition. And then we can insert an orogastric or nasogastric tube to remove the contents of their stomach and reduce the risk of aspiration and actually make it easier to ventilate the patient. Again, you want to secure the endotracheal tube because it's very easy for the tube to pull out when you move the patient or move the patient's head, and oftentimes it's more difficult to intubate the patient after you have intubated them the first time. So reintubation, more difficult. And as I mentioned before, never take your hand off the endotracheal tube before it has been secured with either tape or a commercial device. You want to hold on to that. That is the patient's lifeline. Don't take your hands off it. So how does this look? If we put all this together and do a successful intubation, what does it look like? Well, let's take a look. Again, we're going to insert the laryngoscope blade into the patient's right side of their mouth, holding it with our left hand, sweep the tongue to the left, try and visualize the chords. Once we've seen the chords, our assistant will hand us the endotracheal tube. We will insert the endotracheal tube under direct visualization. Once we make sure that it's in, we'll remove the laryngoscope blade, but remember, never take your hand off that endotracheal tube. We're going to attach it to an end-tidal CO2 detector. We're also going to listen for breath sounds, and if we're in the right spot, we're going to hear breath sounds. We're going to see color change from purple to yellow with the end-tidal CO2 detector, and we're going to see a maintenance of a normal oxygen saturation. A successful intubation because the patient, we prepared, we pre-oxygenated, we positioned the patient, we placed the tube, we ensured that we proved that it was in the right spot, and then we took care of post-intubation management. And again, these are the 6 P's of endotracheal intubation. Thank you so much for your attention.